The process of diagnosing cancer is definitely more in the clinical space than preclinical. But I do want to at least discuss the concepts about diagnosing a cancer and staging it. What we want to do is actually talk about what you do with the cells. That is, how do you confirm the diagnosis? And then what do you do to the human, the person who has the cancer, which is effectively staging? The cells are microscopic. The diagnosis is microscopic. For sure, you must obtain tissue. In order to diagnose cancer, you must get a biopsy. The only cancer that's not true is going to be hepatocellular carcinoma. It's the exception. Don't learn that now. Learn, if you think it's cancer, you must get a biopsy. That's because, one, chemotherapy is so toxic. You have to be absolutely sure that that thing is a malignancy in order to give it a toxic treatment. The other thing is that you need to get some sort of prognostic factors and confirmation. How you get tissue, you will not have to choose. But just recognize that it's going to involve either putting a needle, by needle aspiration, or completely cutting something out. Excision, whole section. You could take the entire testicle, you can take the entire kidney, or you can just put a little needle inside the thyroid. You could tap fluid, like a paracentesis or thoracentesis. You can do a CT-guided biopsy. And you can get to that tissue through a number of routes, such as endoscopically. You don't have to choose the route, but know that someone has to go get a piece of that tissue. That gives you the ability to grade the tumor. Grade is microscopic, and also confirm the diagnosis using immunohistochemistry and molecular diagnostics. When we talk about grade, we're looking at two things. One is the degree of dedifferentiation. How anaplastic is it? The other is the mitotic rate. And what we can do is compare the different types of tumors, those that are well differentiated or those that are not. As tumors develop more mutations, they get more and more primordial. They have fewer and fewer cellular targets for us to treat. And then you compare that to the mitotic rate. If that rate is slow, you say it's indolent. If the mitotic rate is fast, you say aggressive. Now, staging has more prognostic value than grade, but grade is also important. If you have a poorly differentiated anaplastic tumor that's also mitotically active, this is bad. The tumor will overgrow the person quickly, and there's no way to treat it. If what you're going for is survival, and notice I said survival, not cure, what you want is an indolent, slow-growing, well-differentiated tumor. While you may never be able to kill it because it's so slow-growing, our chemotherapy won't work, but also because it's so slow-growing, it won't overtake the patient, and you can do things like radiation or surgery to debulk it, and then it takes a long time for it to come back. Aggressive tumors are the most susceptible to chemotherapy, especially when they're well differentiated. But because they're aggressive, that mitotic rate is going to convert into more mutations. So if you have to pick one, this is what you want. Well differentiated, indolent. That's going to give you the idea of the grade, and it can be seen based solely on that biopsy that we did. The bigger reason why you take a biopsy and get some tissue is to confirm the diagnosis. You put it on a slide and you take a look. You see the abnormal nuclei, you can say, okay, that's cancer. You kind of get an idea from which epithelial layer it came from, and then you're able to do stains. We know certain chemicals stain cells a certain color if they're expressing a protein. We have them. You don't have to memorize most of them. Once we know that the stain is taken hold, we can confirm the type of tissue that it is. Skin cells express different proteins than fibroblasts, than smooth muscle cells. And so by using what we know about certain cell types, we can confirm, one, that's cancer, and two, from what organ it came from. But now, more importantly, we can determine what are the characteristics of this tumor. We have a longer lecture on molecular diagnostics and genetics. It's number 8. But I want to just give you an idea, but with a few examples, which are certainly high yield, to illustrate this point. We came across a little bit of this already in the chemotherapy lectures, where we said we can test to see if a person who has breast cancer is HER2/neu positive or not. HER2/neu activity means that we can use a monoclonal antibody against the HER2/neu receptor. That was trastuzumab. We can also test with a biopsy if this breast cancer is ER/PR positive, estrogen receptor, progesterone receptor positive. If yes, depending on age, and you don't have to make this choice just yet, you can use a SERM or an aromatase inhibitor. By having the biopsy, using the stains or molecular diagnostics, we can actually tailor the therapy to the cancer. Now, there's more to it than that. We've also seen in CML, the JAK-STAT receptor tyrosine, caused by the translocation of 922, BCR-ABL, the Philadelphia chromosome. We can actually enhance the DNA to determine if the translocation gene product is there using PCR. Or we simply can just light up a karyotype with some neon lights using FISH to see if actually the Philadelphia chromosome is present. If they do indeed have CML, we have imatinib. Again, tailoring our therapy based on the molecular diagnostics we've done. And there are other tests, and I think one of the things you should look at is CD markers. CD markers on flow cytometry help determine what type of cells are in a certain place. ALL is CD10 positive. It's also called C-ALA, which is convenient because it's got ALL right in the name. And then for lymphomas, you can test to see what this lymph node, what is it expressing. If you have CD15 or 30 positive, then you have Hodgkin's lymphoma. If it's CD15 and 30 negative, it's not. And you can also do things like test for T cells, CD markers, usually single digits or double digits. The higher you go, the more likely it is to be a B cell. These are just some examples. They're short wins. They're not necessarily more high yield than another, but the point is you get the tissue to confirm the diagnosis, determine what this cancer is expressing, what it's doing, determine your targets of therapy, and also determine how bad the grade is. Once you've done that, you give the patient the bad news, and then you stage. Staging uses the TNM system, and I am going to speak only of carcinomas, epithelial tumors. The problem with cancer is that there are so many different types. The staging patterns are different for each individual cancer, and you don't have to memorize staging patterns. Absolutely not. Never will you have to say, here's a bit of information, what stage are they? No. If they do that, it's either going to be 1 or 4 because it's so obvious. Nor will you have to choose a chemotherapeutic regimen or combination of radiation, surgery, and chemo. All we want you to do is understand, how does this work? So I'm going to be speaking about epithelial cancers, carcinomas, because it's the most generalizable. The TNM system takes into account the tumor size and degree of invasion locally, the nodes, and how many metastases. Each T, N, and M get a number. The higher the number, the worse it is. And generally, because we are talking about tumors that spread through the lymph, carcinomas, epithelial tumors, Mets generally means worse than nodes means worse than tumor invasion. And stage generally comes down to one of 4 things. Stage 1 means there has been no invasion, and cure is possible with surgery. This is why we screen, to catch cancer early. It's also detectable on biopsy. If you've got an epithelial cancer, you look at the basement membrane. If it's intact, no invasion. If it's broken and the tumor is getting into below the basement membrane, they've got invasion. On the opposite side is stage 4. Stage 4 is really bad. This means there are distant metastases. This is about time. There are some cancers that can respond even at stage 4, but the gestalt should be, if stage 4, that person's dead. And now it depends how long they have left and how much they want to fight. That is, do they want to suffer through treatments and chemotherapy to get more time, or are they okay with taking it easy, having the highest quality of life left, rather than fight and suffer? That's up to the individual patient, and has to be up to the oncologist who helps them decide. In between, you've got stage 2 and 3. The main difference is that stage 2 does have invasion, but it hasn't made it to the nodes yet. You might still go for cure here, but remission certainly has a high chance. And this is important. We use the word remission and relapse, not cure. You can cure cancer only when you're stage 1. No invasion found early, cut it out. Otherwise, we're going to say remission. We silence the growth of the cancer, and we hope it's gone. But eventually it may come back because we're not sure if we got it all. Stage 3 has both invasion and positive nodes. Your chance of remission is poor. Again, not all-encompassing, but 2 and better, chance to survive the cancer. Not just put it into remission, but actually be free of it. 3 or worse, that person's on borrowed time and are likely to die from it. The staging is based on the tumor size and invasion, biopsy, presence of nodes, and metastases. This is generally going to be done by imaging. And ideally what was used is the PET-CT. The pan scan also works, head, chest, abdomen. Sometimes you need a biopsy, such as a sentinel lymph node. Actually, you have to remove the node itself. Sometimes you can get away with just doing a bone scan. Different cancers are different, but in general, imaging, once you've made the diagnosis, if there is invasion, you're either going to go to the sentinel lymph nodes or you're going to do a scan of the entire body to find if there are distant mets or not. Once you've made your diagnosis, you're going to treat. And this last part, students have a lot of trouble with, especially new students. You do want to be familiar with serologic markers. Serologic markers are going to be proteins that the cancer produces, and we as providers can draw samples of the blood and detect the level. Never are serologic markers used for diagnosis. In fact, you shouldn't even get them, because the presence or absence of a serologic marker has nothing to do with the diagnosis. Presence or absence of a serologic marker has nothing to do with the predicted prognosis. The only way it's useful is for tracking relapse and remission. Let's say a guy comes in with prostate cancer. His PSA was found to be high. Now, his PSA was high because it's prostate cancer, and we were preparing to do surgery, so we got pre-op values, just so we could tell, is there relapse or remission? It's surgery. PSA goes to 0. And then we check every month. Remains 0. And this last month, it starts to rise. Here is in remission. The prostate is removed and nothing else can make PSA. Remission all this time, relapse. If something's making PSA. And since he doesn't have a prostate, the only thing left must be the cancer. So while you should link a serologic marker to a small set of cancers, you should memorize them. Don't use them for diagnosis. The alpha-theta protein can actually be used to make the diagnosis of hepatocellular carcinoma, and it can also track it. And AFP will be seen in non-seminoma, testicular cancer. The beta-HCG will be elevated in choriocarcinoma and trophoblastic disease. The CA19-9, pancreatic cancer. CA125, ovarian. The CEA is actually of any carcinoma of any kind, but often it is linked in textbooks with colon cancer. And lastly, the PSA, prostate. Again, it's important to realize, though, that these serologic markers and the levels in the blood are only a way of tracking remission and relapse, not making the diagnosis. The diagnosis is made with tissue biopsy, so you can determine the grade and then confirm the diagnosis using molecular diagnostics. Once you've made the diagnosis on a biopsy, on a microscope slide, then you do imaging to determine what their stage is. The stage and the cancer itself, its individual function, and how well differentiated it is will determine what you use to treat it. Whatever method you choose, you can then use serologic markers, if one were elevated, to track progress. That's diagnosing cancer.